Oh, it's interesting. It's got the cheat notes from the other. This is ready? Good. So I have to wait 1 more minute. They're very precise here at AADR, IDR. What's interesting is that my notes are here because I've pirated slides from a whole bunch of different presentations. But I guess we're going to wait another, whatever, minute. 12:44. Is it 12:45 yet? Ah, very good. There we go. Well, welcome everybody to this session. We're going to be chatting about dental implant intervention for syndromic and non-syndromic childhood partial edentulism. I'm delighted that we have dental students here, their first AADR, their first research meeting, and I encourage you to continue those pursuits because I have a bias. I think that students interested in research will probably be interested in being educators. So I'm going to tell you a little bit about myself. So I spent 15 years at NYU. I was the associate director of the grad pros program there, and I've been at Montefiore Medical Center for a quarter century plus. That's in the Bronx, so I'm Bronx born and Bronx bred, Bronx trained. I served at a program that was from the beginning to the end. It's a hospital system near my private practice where I would refer patients that couldn't afford treatment, and we treat them in the residency training program. And my office is right down the street from a very large hospital, North Shore LIJ medical system. Currently, I'm at Stony Brook. My primary affiliations are Montefiore Medical Center in Stony Brook, and I have a couple of titles there. I'm also a clinical professor at the Hofstra Northwell School of Medicine. So as a prosthodontist, we interact with a lot of different medical specialties, you know, surgical specialties, plastic surgery, oral surgery, and radiation oncology, medical oncology, because we treat patients with a very unique treatment needs. And I'm in private practice. I'm also a dual citizen. So I'm also licensed in Ireland, and I'm very proud to be a clinical visiting professor at the School of Dental Science at Dublin Dental Hospital. So that's in Dublin, Ireland. And I was renewed there, and the dean of that dental school was, until recently, was a prosthodontist. I love dental schools where the dean is a prosthodontist. So I have a lot of letters after my name. So I'm actually a fellow of the Royal College of Surgeons of Scotland and a fellow of the Royal College of Surgeons of Ireland. Okay, I think the Irish got jealous because I became a Scottish fellow first. But I'm a clinician, so I was a general dentist for a dozen years, then only in America I went back and trained. I got paid to become a specialist. So what happened was I started working for a general dentist and then took over the practice and branded it as a prosthodontic practice, came up with the name Academic Prosthodontics of Long Island. Dr. Dana Marzocco, Dr. Gluck retired, and Terry went off to his own adventures, and now Dana Marzocco works with me, so she teaches at Stony Brook on Tuesdays, and I teach there on Fridays. So what we're going to talk about. So as a maxillofacial prosthodontist, that's a subspecialty of prosthodontics, I'm actively involved with the Children's Hospital and a craniofacial team. So if you look at the long list of all the people that participate in these patients' health that have all kinds of syndromic and non-syndromic issues, you see the whole laundry list of dental specialists, but the one that I think counts the most is this geneticist. I like a geneticist because they don't have the dopey dental bias. They're physicians, and they can help strategize what's best for this actual patient, okay? Because if you're an oral surgeon, you want to do what? Oral surgery. So if you're a pediatric dentist, you want to do what? Pediatric dentistry. If you're a prosthodontist, you want to do what? Make prosthetics. So he goes through all that, and he has the ability to determine the sequence of treatment by team consensus, okay? He also provides counseling for parents and the child patient, because for me, what I've learned is that some of these syndromes, the child has what's called microtia. They don't have an ear, all right? So mommy and daddy don't want a fake ear that we would make. They want what ear? They want an otologous ear. And then I've been with those kids where I went up to Toronto to a famous cancer center there, craniofacial center, and I talked to these kids. Every summer while they were teenagers, they had to go in and get operations to make a surgically reconstructed ear that sometimes is not satisfactory. And then they find out they can just lop that off, stick 2 implants in, and have an ear. So the only reason you have an ear is to hold up your glasses, okay? Otherwise, you have longer hair, nobody knows, and you can only see one ear at once. So if you look around the room right now, you can't see two ears, only one. No, you gotta be up here to advance this. Oh, there we go. So if we look at the evolution of team staffing and, so even now, you still have all these types of specialists. We still don't have enough, and maybe it's just that there's not enough geneticists around to populate in here, but I really think it's going to be, very much more important as time goes on. Because when I was in dental school, genetics had no basis in dentistry. Nobody taught me genetics about anything to do with teeth, okay? But now it's really a part of it. So it's almost like science fiction, the genetic basis of oligodontia. So as we know, there's hypodontia. So some people are born without a tooth, okay? So hypodontia is one factor. And then there's oligodontia, which is missing more than 6 teeth. And then rarely, but it can happen, some of the patients that present have anodontia. That's complete absence of teeth, okay? And what do we know? There's a genetic basis for this, all right? So the MSX gene and the PAX9 gene, they're some of the first genes that were discovered that's what dictates whether you have teeth or not, all right? And even more importantly is that this paper is from, almost 15 years ago, but it piqued my interest because it was published in the Journal of the American Dental Association. This is not a typical place for this, and sometimes this is part of the fault of the peer review process. But what this is saying is that there's an association of increased incidence of epithelial ovarian cancer. So I myself, if I'm treating a 12 or 14-year-old, young lady missing, a lateral incisor, I don't feel comfortable telling them that they're at risk, possibly for increased incidence of epithelial ovarian cancer. But who is comfortable telling them that? Yeah, the geneticist. So it's very easy. I just turf the problem off to my specialty colleague, and I make kind of like, oh, I think it's a good idea if you and your daughter see the geneticist. And well, why would I need to see the geneticist? Oh, I don't know. They often like to speak to patients like you. So I give a very nebulous thing because I'm not comfortable doing it. So we kind of touched on this before, what hypodontia is, what oligodontia is, and some of these kids are syndromic. So with the cleft palate, they'll have multiple missing teeth, et cetera. And then there is a higher incidence, it's around twice as more likely that females are going to be missing these teeth. And you're going to see evidence of this in this presentation, all right? The one thing I want you to not take back to your dental schools is that we implant recklessly, okay? We place implants. No, it's very specific. So our Italian colleagues were placing implants in adolescents that were missing teeth. And what happened is the rest of the teeth developed three-dimensionally. The alveolus developed and erupted, et cetera. So what was left behind? The implant, because essentially it's an ankylosed tooth. So we know not to do that. So we phase them through time to move it out. So in medicine, when they have the conundrum of not knowing what to do and when to do it, they go through what's called the Delphi process, okay? And that's a way that you can come up with treatment parameters for very small patient pools. And I was very fortunate because I was here in attendance, and this used to be what's called a lunch and learn. So normally when you have a focused lecture like this, we'd be eating, and there'd be about 10 of us, and we would chat about this type of thing. So now this is lunch and learn without the lunch, right? So it's called a focused lunch. But I often would go to these on topics of interest to me, because I find that you're going to be speaking to somebody who has, a fair amount of knowledge in this field, and you learn a lot. So with the Delphi process, they sent out 100 questions, right? And then pretend the people in this room got these questions, and 80 of the questions we all agree on. We all pick answer A for whatever it is. Then 20 of them, you have a wide variety of answers, and that's why you get together to discuss these troubling questions. What are we doing, and how do we do it? So I was very fortunate, and I'm not too savvy with the computers. I'm very proud I was able to import the American flag in. So those are 3 US prosthodontists that went to London, in 2009 to figure out with our other colleagues, a couple of prosthodontists, and orthodontists and pediatric dentists, et cetera, to figure out what was going on with that. So to the far left, that's my colleague in UCSF, Arun Sharma. And in the middle is the new dean at Iowa, Dr. Clark Stanford. And I'm lurking in the back with darker and more hair. All right, so that's one of the problems of getting old. If you quote me, date me, because sometimes I have different theories at different times in my evolution. So we published 2 papers regarding, what do we do with these patients? So ectodermal dysplasia, it's mostly oligodontia, but they can also have anodontia. And we're going to review some of the treatments that we do with the anodontia patients, because in those patients, we can, in fact, place implants, quite early in time. So what is aggressive intervention? And what is reckless intervention? And there's no harm in non-intervention. So remember, dentistry, for the most part, is if a patient's asymptomatic, there's nothing to do. They can always remain as is. It's elective treatment, right? What is aggressive intervention? Some people think I'm overly aggressive in prescribing, implant therapy for, say, a 5-year-old child with anodontia. But if they have a cleft palate, maybe that's not such an aggressive intervention. Maybe it's not reckless because it helps keep their obturator in position, okay? So one of the things, I'm in the Bronx, New York, which is a medically underserved area. And so we don't treat the captains of industry there. So resources is a big thing with us, the finances to do the treatment. And sometimes these are covered in New York State. There's a law that allows some reimbursement because of via medical insurance, because these are somewhat handicapping oral disabilities. But compliance with instructions, with if you have complex prostheses, who's going to do it? The kid's going to grow, the child is going to grow 3-dimensionally. So you make something at age 5, and now at age 10, it's going to be remade, or at age 15, et cetera. Then also you have this, you're treating a patient, but you're getting the consent from the parent. So now we get another layer of complexity, because in my career, I've already been, and I'm going to show you that in the analog world, we make casts, right? And then what do we do with them? Well, I like to give them to the parent with hopefully a second set of implant componentry, because I've lived through the obsolescence where implant systems that were around a quarter century ago, they're no longer around. And now you have integrated implants and no ability to do what? Make replacement prostheses. And then a lot of times for 3-dimensional reasons, I'm going to put a young patient into what some people consider less desirable, a removable prosthetic. And I find a lot of times it's the indicated prostheses. So it's a removable prosthetic, and you can always convert it to a fixed prostheses. So here we go. We got a little 5-year-old shows up at Montefiore Medical Center, and he's got Rap Hodgkin's form of ectodermal dysplasia. Luckily enough, it's pretty rare. And he's a candidate for dental implants. Kurtz, you're crazy. Dental implants on a 5-year-old. Yeah, well, he's got no teeth, and there's no danger of him having teeth. He did sneak in one tooth on a recall. You see that? There's a little tooth bud there. It's probably a 12-year, well, no, so it's probably a 6-year delayed ectopic molar or another tooth. But fascinating enough, it helps with retain his maxillary prosthesis. And then they thought I was very clever, and I managed to make him grow hair as well. No, that just happened. He was shaved head in that picture, and now he's got hair there, because, as you know, it's a disturbance of the nails, the hair, and the teeth, ectodermal dysplasia. But what we see here is we know, believe it or not, that if the child has anodontia, between the mental foramina, after 3.5, that's all it's going to grow. If there is no teeth, the dimensions of that intraforaminal mandibular bone is set at that very young age. And subjectively, patient dissatisfaction, I got news for you. Kids are terrific with removable prostheses, and it's a pleasure making dentures for them, and they're a lot of times more compliant, and they don't want to be different from their little friends, Johnny and Joey and whoever they're playing with. They have no teeth, and guess what? Now when they have teeth, they fit into society. And that's actually age inappropriate teeth. So he should really have somewhat, in a child of 5, he should have some diastomata. We don't want him really looking like this. But guess what? His contemporaries, they don't know that the teeth are, grown-up teeth in a child. They're just happy the kid has got the teeth. So this is a very interesting treatment to follow up because it involves a level of malpractice, probably on my part. He had a tooth when he came in, and then unfortunately in the Bronx, things happen like fist fights, and in fist fights, they get a blow to the mouth. So if you look very carefully and closely at the panoramic on the far right, that's actually the last root canal I did. It's about 25 years ago, whatever. But he came in, he had snapped the tooth, and I like teeth because they're smart. Implants are dumb. Teeth have proprioception, and I wanted this thing to stay in there, so I did an endo, and the tooth was decoronated, and we left the root in there. What's interesting to note is that he disappeared, which sometimes happens. I'm not saying he went away. So in the Bronx, like if you say in Iowa that you're going away, it's understood that you're going away for vacation, right? So unfortunately, some of the street slang in the Bronx, it means you're going away. It means you're going away for 2 to 4 years. You're going to be incarcerated, okay? So sometimes people disappear in that manner. But if you look, his alveolus actually grew 3-dimensionally around that. That was his original denture made by a resident at Montefiore, Anthony Pagano. And then when this patient showed up under my supervision, we, at the time, in the early mid-90s, we didn't know about 3D growth. We didn't know if we created a bar prosthetic, would that in fact inhibit the growth of the mandible? So we go ahead and we check something out, and it's actually in agreement with the literature. So as the mandible grows down and forward, it kind of auto-rotates. And guess what? The implants that were at one time vertical are now what? Yeah, they're tilted this way. But it doesn't affect it because the advantage of a bar is that you can correct misangled or angulated implants. So if you see here, these types of implants are something you won't see anymore, all right? So they're called IMZ implants. A very interesting approach. They had an intramobile element that was meant to do what? Mimic the effect of the periodontal ligament. And it had these unique overdenture attachments. So instead of, it's got the female is in a kind of like polyurethane plastic attachment, but it gave stability to the prosthetic. So, the child's masticatory function, well, it's pretty good. It's subjective, but he could eat away, and I know that he could eat away because if you look, he has what's called a functionally generated path. Okay, you see the way he ate through that incisor, tooth number 7 on the denture, he's gnawing away on it. So it's in agreement with the literature. It's a paper from Jomi where they have a case report much, very similar to this. And it was an opportunity for a resident to, learn more. I think it's a privilege to teach this type of patient population. So now we're seeing mostly patients with severe expression of ectodermal dysplasia.